This is Karen, and I will be hosting tonight's webinar on opioid addiction and substitution therapy. This is part 2 of our talk on non-opioid strategies. Okay, so this is just some disclosures. I have no current or past relationships with commercial entities, and I have received a speaking fee from the Ontario Pharmacists Association for this learning activity. These complimentary webinars are made available through the funding from the Ministry of Health and Long-Term Care. Okay, so tonight we're going to talk about some of the first-line pharmacotherapies that we commonly use to manage common nociceptic and neuropathic pain conditions. We'll compare and contrast the clinical and certainly the safety parameters around these therapies. We'll also discuss a lot about non-pharmacological modalities that can be used in conjunction with the medications to manage chronic pain, and then various evidence-based patient pain management resources, both from the online platform as well as in-person programs. And then lastly, describe the role of the pharmacist within the interdisciplinary team in the management of chronic pain. So when we think about pain, we traditionally delineate it to 2 major categories. The first category being nociceptic pain. So a very general definition of this is normal processing of a stimuli that damages normal tissue or has the potential to do so if it's prolonged. And furthermore, this is broken down into 2 types of, or 2 locations, I would say, somatic and visceral. So somatic nociceptic pain happens in the bones, the joints, muscles, skin, or connective tissue. And examples of this are sprains, fractures, or OA, or even sunburns as an example. The type of pain described here is more localized, aching or throbbing, and often it's worse with movement. Contrast that to visceral pain. This occurs in the visceral organs, so in the lining of the heart, the GI tract, or the pancreas. And the visceral pain is triggered by smooth muscle contraction or distension, stretching out the capsule surrounding the organs. And the capsule has lots of nerves. So this is where the pain sensation comes from. Examples of this is growth, tumor growths, obstruction of the hollow viscus, pancreatitis, appendicitis. This type of pain is local, or it can be non-local, meaning that it can refer to different locations in the body. It's constant or dull, can be like cramping qualities, and it's less affected with movement. The other big category that we often see in practice is neuropathic pain. This is abnormal processing of the sensory input by the peripheral or the central nervous system. And sensitization plays a huge role in this type of pain. Neuropathic pain can sometimes be called pathologic, particularly if it causes continued pain with no purpose in terms of protecting the patient in terms of that presentation of pain. Neuropathic pain can occur in the peripheral nervous system. So the peripheral nerve damage occurs in diabetic neuropathy, postherpetic neuropathy, cancer-like pain, or carpal tunnel. And patients will describe this as burning, stabbing, pins and needles, shock-like shooting or tingling pain. In the central nervous system, we also have a lot of certainly nerves there. So in the brain or brainstem or the spinal cord, if that's damaged, you have sympathetically mediated pain associated with the dysregulation of the autonomic nervous system along the central nervous system. Examples of that clinically is post-stroke pain, CRPS, which stands for Complex Regional Pain Syndrome, and MS, to name a few. So let's start talking about how we think about managing pain overall in terms of a bigger picture. I'd like to put this diagram up from the WHO, or the World Health Organization. It's their long-time analgesic ladder. And this traditionally, this ladder was validated in cancer-related pain, but certainly we use these concepts in non-cancer pain as well. So this ladder shows a stepwise approach to the selection of analgesics for pain relief. And the 4 principles it's based on is use of oral analgesics, analgesics that should be given on regular intervals as opposed to PRN use. Analgesics should be given based on the patient's reported pain intensity. And lastly, the dose of pain medication is based on, obviously, their response. So let's think about if we go from step 1, a person has maybe mild pain, they may start with a non-opioid analgesic, plus or minus some adjuvants, which are listed in the italics on the bottom there. And before a new medication is introduced, it's important that we try these medications for an optimal amount of time before moving on to the next rung or the next step. Step 2, again, if you have more persistent or increasing pain, you would now further optimize it by maybe adding or switching to a weak opioid, plus or minus non-opioid and or adjuvants. And then finally at the top rungs, when you have really severe pain, the stronger opioids. So let's look at the next few slides and we'll talk about each of these steps more in detail. So step 1, as I mentioned, we start with simple analgesics and medications that are effective in the treatment of mild pain. Mild pain is usually categorized in pain score of 1 to 3 in the visual analog scale. And these include non-opioids such as your run-of-the-mill acetaminophen or Tylenol and your non-steroidal anti-inflammatories or Nsaids. And some examples are listed there. Then in step 2, we move more into the weak or moderately potent opioids to manage more mild to moderate pain. So if a patient is endorsing a pain 4 to 6, then we know they're more moderate pain. And examples of these type of opioids include codeine, tramadol, tipentadol, buprenorphine, and oxycodone. Oxycodone probably is more of the moderate potent opioids, but oftentimes we do see it used commonly in the mild to moderate stage as well.
So here we have step 3 of the analgesic ladder. So this is when you would consider using stronger opioids to manage more moderate to severe pain. So this is pain described as 7 to 10 on the visual analog scale in terms of pain intensity or the numeric rating scale. And some common agents we would use would be morphine, oxycodone. So I know I had put oxycodone in step 2, you know, the weak to moderately potent opioids. But for severe pain, you can also use oxycodone. So that's important to remember that it's a pretty strong opioid. Obviously, hydromorphone, methadone, and fentanyl, to name a few, for your more severe pain conditions.
So the first class I want to look at is the Nsaids, or the Cox-2 inhibitors. And these types of medications are used in nociceptive pain, so that first category we talked about. They're anti-inflammatory and antipyretic. And non-selective Nsaids and selective Cox-2 inhibitors appear to be equally effective if they're dosed at appropriate ranges to manage pain disorders. So there's not one agent that is better than the other. As long as you dose them adequately, they should be equal in efficacy. So Nsaids work by inhibiting prostaglandin synthesis. So you see in the schematic where you have tissue damage, which releases phospholipids, which further develops into arachidonic acid. Arachidonic acid is then broken down by Cox-1 or 2 into to produce prostaglandins. And there are many different types of prostaglandins that are produced. And you can see in the blue box there, if Cox-1 was to break down the arachidonic acid, you have cytoprotective prostaglandins that are purpose is to protect the gastric mucosa and aid in platelet aggregation and clotting. And then contrast that to Cox-2, you have the development of anti-inflammatory prostaglandins and affecting the pain receptors and regulating temperature. So depending on if a drug is more Cox-1 or Cox-2 sensitive, you can tell what type of prostaglandins it inhibit, and furthermore will speak to some of the side effects we see in some of these medications. This chart here shows you some examples of Nsaids and Cox-2, and it's by no means exhaustive, but the most common ones we see in practice. The first, probably lighter box up top from aspirin to naproxen, those are more non-selective Nsaids, whereby they inhibit both Cox-1 and Cox-2, and some of the common side effects are listed there for your reference. The dosing range, again, is for your reference in terms of common doses seen in practice. Then we move on to the more selective Cox-2 inhibitors, the celecoxib, Mobicox, as well as the clofenac. And this type of class generally has significant reduction in gastroduodenal damage because you can recall Cox-1 inhibition inhibits the production of protective gastric prostaglandins. So if you don't have much Cox-1 inhibition, then you have better protection in the stomach. And again, dosage ranges there. Please also note that there's topical agents listed there, which are important for more localized pain. So these are very good for, let's say, knee pain or very small joint pain where a patient can really target that therapy. And the hope is maybe there's less systemic side effects because it's not being swallowed or irritating the stomach. Now, Nsaids tend to have a little more side effects than most milder agents. So it's contraindicated in the first and third trimester of pregnancy. In the first trimester, if a woman were to use this NSAID, they would risk increased miscarriage and malformation of the fetus. In the third trimester, it's associated with increased risk of the premature closure of the fetal ductus aortus. In terms of chronic use, you increase that gastrointestinal side effect, like I mentioned, inhibit platelets, so there's a bleeding risk, renal insufficiency for those at risk for that, as well as hypertension and heart failure. NSAIDs are also associated with increased risk of cardiovascular adverse effects, primarily as it relates to MIs and strokes. And the risk seems to be less with naproxen and lower doses of ibuprofen and Celebrex. CV risk increases with diclofenac and indomethacin, and it's really the thought is it's more of a dose-related phenomenon. Now, the cardiac risk, there's really no clear relationship between specificity of the Cox-2 versus Cox-1 with the risk of CV events. When you look back at the chart, there's really not a clear pattern in terms of that CV risk. So the question is maybe there's other mechanisms that might be involved in increasing those cardiovascular risks, such as effects on prostacyclin or thromboxane, endothelial function, or maybe inhibition of nitric oxide, blood pressure obviously, and volume retention, and a lot of other maybe renal effects in terms of retaining fluids that might put a strain on the heart. Some of those factors may play in on why NSAIDs could have some risk around cardiovascular safety. Acetaminophen is probably a lot of patients' first go-to. The proposed mechanisms of action are listed there, so many different theories. It's mainly for nociceptive pain and antipyretic effects. Unfortunately, it doesn't have any anti-inflammatory effects compared to NSAIDs, but it's relatively well tolerated with very few drug interactions. So acetaminophen is metabolized by the liver, and there's two pathways. So the major pathway is the drug is metabolized to produce mainly non-toxic water-soluble compounds that are easily eliminated in the urine. And then there's a minor pathway. If you take too much acetaminophen, you override the normal mechanisms to metabolize it, and the minor pathway produces highly hepatotoxic reactive intermediates, which then conjugate with glutathione. With glutathione is not enough in the system. If it's kind of overloaded, then it can't be conjugated and inactivated. So then you have a buildup of these hepatotoxic reactive agents. The dosing range is listed for your reference, and we know that usually we recommend 4 grams per day as a maximum safety for most patients. However, for patients that are on chronic use of acetaminophen, so chronic being months on end or years, we generally anecdotally recommend 3 to 3.2 grams per day. And maybe even lower than that in patients with risk of cirrhosis or using other agents of medications that can affect the liver. So that's all I'm going to really say with regards to nociceptive pain. Certainly we can use opioids for nociceptive pain, but there was a huge module already done previously on opioids, so you can refer to that. But again, NSAIDs acetaminophen are for your first rung, your step 1. Now we move to the different category of pain, which is neuropathic pain. And this schematic shows you how complex the pain pathway is and how different medications can target the different areas of managing some of the neurotransmitters and the pain pathway and the pain signals. This diagram shows the most recent neuropathic guidelines, Canadian neuropathic guidelines in 2014. Though dated, we still use this in practice. And it shows us here that the gabapentinoids, TCAs, and SNRIs are still considered first-line therapies. And it toggles between the agent depending on the patient right? So one is not better than the other. It's really dependent on the drugs that they may be using already. So in terms of drug interactions, patient factors, side effects, that would help you determine which agent to choose between the three. Second-line agents are still considered at this point opioids, and I suspect if they were to update the guidelines, this may change in terms of moving down in terms of where they stand on the use of agents. Third-line therapies are the cannabinoids, and then fourth-line agents are listed in italics in the bottom there. So let's talk about the first big class, the tricyclic antidepressants, what I call an oldie but a goodie. So they are broken down to tertiary amines, which inhibit both norepinephrine and serotonin, and the main drug there is amitriptyline. Secondary amines inhibit also serotonin, but mostly norepinephrine, and the two common medications are diazepamine and nortriptyline. These agents generally require slow dose titration, approximately every 1 to 2 weeks, because often they're not the most well tolerated. And we do want to wait at least 2 weeks at optimal doses, and I showed you the dosing range there, before we can assess efficacy. Now, doses used in pain are usually lower than those used in depression. Dose-dependent side effects are mainly anticholinergic, so very drying drugs, as well as there's arrhythmia potential and QTc prolongation potential. So very important to do your drug interaction check and to make sure patients with underlying arrhythmia are not started on these agents. These can be fatal at overdose, so I would say it's got a narrow therapeutic range, particularly from a cardiac and neurologic perspective. And secondary amines have generally less anticholinergic side effects. So if you have a patient that would benefit from a TCA but yet have trouble with some of the drying side effects, you may want to think about a secondary amine.
So another big agent with regards to neuropathic pain management within the realm of antidepressants is your SNRIs, or your serotonin norepinephrine reuptake inhibitors. So the two main agents that have been more well studied in the literature is venlafaxine and duloxetine. So the first one is venlafaxine, Effexor. It is renally cleared and liver metabolized. At higher doses, we have to be mindful of blood pressure elevation, and that's due to the norepinephrine inhibition. Some doses that we may want to consider is about 150 to 225 milligrams per day to get those good analgesic effects. And we're often seeing it used off-label in migraine prophylaxis and diabetic peripheral neuropathy. So not tons of evidence when we look at SNRIs for venlafaxine. What drug that has lots more evidence in SNRIs is duloxetine or Cymbalta. So this drug is really our workhorse when we think about chronic pain and neuropathic pain. Very similar to venlafaxine, they're very chemically similar, targeting the same receptors similarly. It is renally cleared, liver metabolized, blood pressure concerns as well. Some of the common side effects is nausea, so we require more slower dose titration on initiation. So we start patients often at 30 milligrams and then titrate up to about 60 to 90 within a week. That I would say would be the most efficacious dose with regards to pain. And there's really not much evidence supporting doses above 90, but more side effects. So obviously patients that are using duloxetine for depression or anxiety, they may be using higher doses because that's with regards to depression and anxiety literature. But if it's primarily for pain, I don't target beyond that 60 to 90 mark. Relatively fast acting, so analgesic effect is usually seen about 1 week, and we see maximum effect in 4 weeks. The Health Canada indication is fibromyalgia, diabetic peripheral neuropathy, and low back pain, and it's contraindicated in patients with glaucoma. So acute angle closure glaucoma, and that's likely result of dilation of the pupil of the eye that is caused by some of the adrenergic effects of duloxetine. There might be effects due to the anticholinergic activity, as well as increases in serotonin are also theoretically linked to why this would worsen glaucoma. With duloxetine and venlafaxine, withdrawal symptoms often happen quite quickly if patients miss a dose, so it's important for patients to be compliant. And then lastly, to cap off the antidepressant class is the serotonin or selective serotonin reuptake inhibitors, so your SSRIs. So really this class has shown very inconsistent analgesic efficacy. A couple of drugs within this class of escitalopram have shown some benefit in painful polyneuropathy. Citalopram and paroxetine may have benefit in diabetic neuropathy. But to be honest, in practice, we don't use these agents when we're targeting neuropathic pain. In studies that compared SSRIs to TCAs or SSRIs, have been found to be less effective. So bottom line, if I have a patient that has anxiety, depression, and also have neuropathic pain, if at all possible, we try to switch them to an SNRI, because that's really where the evidence lays to manage some of these pain symptoms.
Okay, so that's our class for the antidepressants. The next big class, I would say, is your anticonvulsants, or this particular drug's the calcium channel alpha to delta ligand inhibitors. So this medication or class of medications is effective for peripheral neuropathies as well as polyneuropathies. They bind to the subunit of voltage-gated calcium channels in the CNS, and essentially it helps to reduce calcium influx into the cell. So you need calcium influx to perpetuate the nerve signal or perpetuate the pain signal up towards the central nervous system. By inhibiting excitatory neurotransmitters like glutamate and substance P is also helpful in terms of that hypersensitivity of the central nervous system, and then it potentiates GABAergic neurotransmission. The two examples in this class of medications that are available in the Canadian market is Gabapentin and Pregabalin, both of which are cleared renally. The main side effects for these medications is really neurologic. They're dose dependent, so a lot of patients complain of dizziness or drowsiness, effects on memory, sometimes word finding. Less common side effects include peripheral edema, incoordination, unsteadiness, and in fact I would say that we're hearing more cases of effect on abnormal thinking and euphoria. A lot of that has been seen in the pregabalin literature. Dosing considerations, so for gabapentin, we want to really slowly dose titrate over 3 to 8 weeks. Adequate trial, again, about 2 months of at least 1,800 milligrams per day. The max dose in product monographs is 3,600 milligrams, but that's really in the realm of seizures and convulsions. In the pain literature, we really don't target that high of a dose. We target 1,200 to 1,800. And again, analgesics for gabapentin is not dose-related. And that's because gabapentin has got a little messier pharmacokinetics. It's not linear in terms of its dose response. In fact, it kind of plateaus around that 1,200 to 1,800 dose, and then you have less benefit in terms of pain and more side effects as we go beyond that. Pregabalin is a sister drug, I'd like to say, to gabapentin, but it's much cleaner pharmacokinetically, so this allows for more rapid dose titration, faster onset of action. Anecdotally or in more studies, they have found that it might be more potent because it might bind to that channel more stronger than gabapentin. Adequate therapeutic trials, about 4 weeks at maximum doses, 600 milligrams in divided doses being the maximum. It has anxiolytic properties, and again, like I mentioned, effects on euphoria. So again, concerns of abuse potential. Something to keep in mind as we, talk about the opioid crisis as another drug to look at in terms of safety. Other anti-epileptics include carbamazepine. The main use for this medication is trigeminal neuralgia. Lamotrigine can be used for central post-stroke pain, but really discrepant results for diabetic neuropathy. Slow dose titration is needed for this drug because of the risk of Stevens-Johnson syndrome. Topiramate small case studies have been used in diabetic neuropathy, but mainly we use this for migraine prophylaxis. And then lastly, valproic acid is for headaches and migraine prophylaxis.
So obviously cannabinoids have come out to be a very popular option for a lot of patients with chronic pain, and probably that's the biggest indication patients would tell you when they're using, let's say, medicinal cannabis is for the area of pain. So cannabinoids is a very interesting agent. So let's just talk about a little bit about the endocannabinoid system. So our own endogenous system has cannabinoids that we release ourselves, and this is within the cannabinoid system. And when we release these endocannabinoids, there are two key receptors, Cb1 and Cb2. Cb1 is primarily abundant in the CNS and the peripheral nervous system, so in the GI, muscle, and fat tissue. And Cb2 is located primarily in the immune system and blood cells. So when we think about pain, we really want to focus more on Cb1 because that's around the central nervous system where the pain pathway and the pain signaling is perpetuated. When we think about the cannabis plant, there are more than 150 phytocannabinoids in the cannabis plant. And of those, only 2 active cannabinoids are used therapeutically, or 2 that we most are familiar with. There are furthermore 2 main subspecies of the cannabis plant, and they differ in morphology, active chemical makeup. And there's a lot of overlap with regards to psychoactive potential. So the 2 main species I'm referring to is Cannabis sativa and Cannabis indica. Now, often a lot of patients really are kind of convinced that certain plant strains have certain kind of activity, so that they're looking for more sativa-only products or indica-only products. But really, there's been so much crossbreeding throughout the years that most of the products that we get out of market are really hybrids with features of both species. If patients are thinking of accessing cannabinoids, there are many areas to which they can obtain these agents. So firstly, in licensed pharmacies, this is where they can get synthetic or what we call pharmaceutical grade cannabinoids. The 2 main ones that you guys are probably familiar with is Nabilone or Sisamet or Sativex, the oral mucosal spray. Street dealers and medicinal dispensaries, you can see I put in quotation marks, are areas where you would get illicit cannabis or cannabis that are not legal or controlled. So those are areas that we do not recommend patients obtaining cannabinoids, just with regards to safety and quality control. Licensed producers via mail order, so that's through the Cannabis Act or the Medical Marijuana Program, and this is available in various forms. We'll discuss further in the talk in terms of the different types of administration. And then lastly, the newer area that patients can get cannabis is the Ontario Cannabis Store. So that's available online or a private storefront. And this is within the recreational realm of cannabis. And again, they offer various different administration forms for cannabis. So I alluded to the previous slide about 2 active cannabinoids that we have most studies about, and that is the THC, so the delta-9 tetrahydrocannabinol, so 9-THC, and this is where we have the psychoactive properties of the cannabis plant mediated through the dopamine system. It, again, like I mentioned, binds as a partial agonist to the CB1 receptor and some CB2, and really altering that dopamine effect, creating some of those psychoactive effects. So that's probably the cannabinoid ingredient that increases that risk of addiction. Cannabidiol, which is CBD, really has negligible psychoactive effect. It decreases binding or functional response to THC when bound to CB1. So what that means is that it helps to offset some of the THC side effects. It has potential anti-inflammatory and analgesic effect and anti-seizure effects. The evidence with regards to CBD with regards to pain is very, very poor. Much of the evidence we have in the literature is around THC, is around the smoke THC side effects. It has potential anti-inflammatory. So I alluded to the previous slide about 2 active cannabinoids that we have most studies about, and that is the THC, so the delta-9 tetrahydrocannabinol, so 9-THC, and this is where we have the psychoactive properties of the cannabis plant mediated through the dopamine system. It, again, like I mentioned, binds as a partial agonist to the CB1 receptor and some CB2, and really altering that dopamine effect, creating some of those psychoactive effects. So that's probably the cannabinoid ingredient that increases that risk of addiction. Cannabidiol, which is CBD, really has negligible psychoactive effect. It decreases binding or functional response to THC when bound to CB1. What that means is that it helps to offset some of the THC side effects. It has potential anti-inflammatory and analgesic effect and anti-seizure effects. The evidence with regards to CBD with regards to pain is very, very poor. Much of the evidence we have in the literature is around THC, is around the smoked forms, but if we're looking really at, let's say, primarily oil forms of CBD, the evidence is very, very limited. So we're really extrapolating a lot of animal studies as it relates to CBD's role in pain. Anti-seizure, there's lots of evidence with regards to that. So we know in the States there is a CBD-only product, an oral product, which is Epidiolex. So certainly we are watching closely post-marketing of the use of this agent in terms of safety, learning from, So I alluded to the previous slide about two active cannabinoids that we have most studies about, and that is the THC, so the delta-9 tetrahydrocannabinol, so 9-THC. And this is where we have the psychoactive properties of the cannabis plant mediated through the dopamine system. It, again, like I mentioned, binds as a partial agonist to the CB1 receptor and some CB2, and really altering that dopamine effect, creating some of those psychoactive effects. So that's probably the cannabinoid ingredient that increases that risk of addiction. Cannabidiol, which is CBD, really has negligible psychoactive effect. It decreases binding or functional response to THC when bound to CB1. So what that means is that it helps to offset some of the THC side effects. It has potential anti-inflammatory and analgesic effect and anti-seizure effects. The evidence with regards to CBD with regards to pain is very, very poor. Much of the evidence we have in the literature is around THC, is around the smoked forms, but if we're looking really at, let's say, primarily oil forms of CBD, the evidence is very, very limited. So we're really extrapolating a lot of animal studies as it relates to CBD's role in pain. Anti-seizure, there's lots of evidence with regards to that. So we know in the States there is a CBD-only product, an oral product, which is Epidiolex. So certainly we are watching closely post-marketing of the use of this agent in terms of safety, learning from, reports around drug interactions to help guide some of our management of CBD-only products as it relates to pain.
So this next slide talks about the pharmaceutical grade cannabinoids, and I already alluded to the main agents that are available in the Canadian market is Sisamet or Nabilone, as well as Sativex. And Sisamet is a capsule, and it has it's basically THC, it's synthetic THC, whereas Sativex is a mix of THC and cannabidiol. Both of them are really not initially indicated for, all types of pain. Nabilone was indicated for refractory nausea and vomiting associated with cancer chemotherapy. And then Sativex has some indication in neuropathic pain for MS. So a lot of its use now has been off-label.
So medical cannabis, the legislation has changed over the years. And what used to be under the access for cannabis or to cannabis for medical purposes regulation, so the ACMPR, now has been replaced by what we call the Cannabis Act. So new regulations have replaced this old act to improve patient access, essentially. So there hasn't been many changes, but the biggest one is around how patients can access cannabis. So individuals are authorized by their healthcare practitioner, so that can be your physician or nurse practitioner, to use cannabis for medical purposes. So they can purchase quality controlled cannabis from a Health Canada federally licensed seller, or they can produce a limited amount of cannabis for their own medical purposes. Or the last area is to designate someone else to produce it for them. So you can refer to the website I have here to read about this legislation around access. There's forms to guide patients if they do want to engage in the use of cannabinoids. There are particular documentation that needs to be filled out by their care provider before they can be part of this program.
So cannabis or marijuana can be many ways. Most popular, obviously, is inhalation. Delivery advice. So I've provided some examples such as hand pipes, water bongs, rolling papers or joints, probably the most common we hear from our patients, as well as vaporization. Of these methods, we recommend if a patient is going to use it for medical purposes to vaporize, because smoking a joint actually has a lot of adverse effects on the lungs, probably worse than nicotine smoking because of the high heat causes a lot of production of carcinogens, whereas vaporization does not need such a high heat to release the active ingredient. And in fact, we often tell patients too that vaporization is more efficient. It doesn't waste as much as the cannabis because it doesn't burn off a lot of the active ingredient. Oral agents include tinctures or edible oils. Patients either drip the oils right into their mouths or they cook or bake with it. And then there's topical agents. So again, using oils to rub the affected area, creams. I've heard about suppositories. And really, the dose is very hard to standardize because of the different strains that are available. If a patient is cooking it, how high a temperature are they cooking it? Would it kill off some of the active ingredients? So it's really hard to control for a lot of this. Now, the absorption rate varies between the delivery rates. So certainly absorption of inhalation is much faster within a few moments or minutes, and it lasts about maybe 30 minutes to 4 hours. Contrast that to oral intake. So if a patient were to ingest cannabis, the onset is about 30 minutes to closer to 2 hours, lasting 3 to about 12 hours. So again, depending on how they take it will affect the kinetics. Thinking about efficacy. So cannabis or marijuana can be delivered many ways. Most popular, obviously, is inhalation. Delivery advice. So I've provided some examples such as hand pipes, water bongs, rolling papers or joints, probably the most common we hear from our patients, as well as vaporization. Of these methods, we recommend if a patient is going to use it for medical purposes to vaporize, because smoking a joint actually has a lot of adverse effects on the lungs, probably worse than nicotine smoking because of the high heat causes a lot of production of carcinogens, whereas vaporization does not need such a high heat to release the active ingredient. And in fact, we often tell patients too that vaporization is more efficient. It doesn't waste as much as the cannabis because it doesn't burn off a lot of the active ingredient. Oral agents include tinctures or edible oils. Patients either drip the oils right into their mouths or they cook or bake with it. And then there's topical agents. So again, using oils to rub the affected area, creams. I've heard about suppositories. And really, the dose is very hard to standardize because of the different strains that are available. If a patient is cooking it, how high a temperature are they cooking it? Would it kill off some of the active ingredients? So it's really hard to control for a lot of this. Now, the absorption rate varies between the delivery rates. So certainly absorption of inhalation is much faster within a few moments or minutes, and it lasts about maybe 30 minutes to 4 hours. Contrast that to oral intake. So if a patient were to ingest cannabis, the onset is about 30 minutes to closer to 2 hours, lasting 3 to about 12 hours. So again, depending on how they take it will affect the kinetics. Thinking about efficacy. So for various forms of cannabinoids, either pharmaceutical grade, so the oral or the spray, or the cannabis plant, smoked or vaporized, that's probably where most of the evidence lies. So there's not a lot of evidence looking at edibles or topicals. Really, most of the evidence is around these forms. It's still considered third line, as you recall from the neuropathic pain guidelines. But there's been a lot of new recent reviews. Overall, it's still showing that there's some small or moderate efficacy in clinically meaningful pain reduction in peripheral and central neuropathic pain. The effects on function and quality of life are still unclear. And, the big one is there's not a lot of trials, efficacy trials or effectiveness. So cannabis or marijuana can be delivered many ways. Most popular, obviously, is inhalation. Delivery advice. So I've provided some examples such as hand pipes, water bongs, rolling papers or joints, probably the most common we hear from our patients, as well as vaporization. Of these methods, we recommend if a patient is going to use it for medical purposes to vaporize, because smoking a joint actually has a lot of adverse effects on the lungs, probably worse than nicotine smoking because of the high heat causes a lot of production of carcinogens, whereas vaporization does not such a high heat to release the active ingredient. And in fact, we often tell patients too that vaporization is more efficient. It doesn't waste as much as the cannabis because it doesn't burn off a lot of the active ingredient. Oral agents include tinctures or edible oils. Patients either drip the oils right into their mouths or they cook or bake with it. And then there's topical agents. So again, using oils to rub the affected area, creams. I've heard about suppositories. And really, the dose is very hard to standardize because of the different strains that are available. If a patient is cooking it, how high a temperature are they cooking it? Would it kill off some of the active ingredients? So it's really hard to control for a lot of this. Now, the absorption rate varies between the delivery rates. So certainly absorption of inhalation is much faster within a few moments or minutes, and it lasts about maybe 30 minutes or 4 hours. Contrast that to oral intake. So if a patient were to ingest cannabis, the onset is about 30 minutes to closer to 2 hours, lasting 3 to about 12 hours. So again, depending on how they take it will affect the kinetics. Thinking about efficacy, so for various forms of cannabinoids, either pharmaceutical grade, so the oral or the spray, or the cannabis plant, smoked or vaporized, that's probably where most of the evidence lies. So there's not a lot of evidence looking at edibles or topicals. Really, most of the evidence is around these forms. It's still considered third line, as you recall from the Neuropathic Pain guidelines. But there's been a lot of new recent reviews, and overall, it's still showing that there's some small or moderate efficacy in clinically meaningful pain reduction in peripheral and central neuropathic pain. The effects on function and quality of life are still unclear. And the big one is there's not a lot of trials, efficacy trials or effectiveness trials comparing cannabinoids and other active treatments, which is what we want to know, right? How is it compared to our current adjuvant therapies?
So, we talked a lot about a bit about cannabis efficacy in the previous slide. And you can tell already that really the evidence around chronic pain is pretty poor, and that the role of it is primarily in neuropathic pain. So what really is concerning is more of the side effects and the safety profile of cannabinoids that we're seeing more and more patients present with. So if patients smoke it, certainly there's concern around
Thinking about efficacy, so for various forms of cannabinoids, either pharmaceutical grade, so the oral
So, we talked a lot about a bit about cannabis efficacy in the previous slide. And you can tell already that really the evidence around chronic pain is pretty poor, and that the role of it is primarily in neuropathic pain. So what really is concerning is more of the side effects and the safety profile of cannabinoids that we're seeing more and more patients present with. So if patients smoke it, certainly there's concern around impaired respiratory function. And that increases risk of stroke in patients with coronary artery disease. And, there's lots of sequelae with regards to chronic respiratory conditions. The mental health perspective is also very concerning. So patients with high risk, so meaning patients with lots of family history of schizophrenia or they have schizophrenia themselves, the use of cannabis can really precipitate psychosis. It can also worsen symptoms related to anxiety, depression, as well as PTSD symptoms. And in patients with bipolar disease, cannabis can worsen mania. I do want to pause that a lot of these side effects that we're talking about are driven through the lens of the THC. So what we know is many of the side effects that people present with is due to the high doses of THC, more so than the CBD. Going back to the side effects, other things that we worry about is a cognitive side effect. So we know that cannabis is a CNS depressant, so there's concern around reaction time and drowsiness and dizziness. Impulse control and attention is also affected when we use cannabis acutely. Negative effects on learning and low motivation. We worry about patients particularly under the age of 25, and that's a kind of more of that caution piece in the end of this slide, but I think it links back to that cognitive side effect that, at the age of 25, that's really when full neural development has completed. So anyone using cannabis under the age of 25 is really putting themselves at risk with regards to long-term cognitive sequelae, because their brains just have not been fully developed. And when you add in a psychoactive agent, there's concerns around that development. I alluded to the fact of THC and its effect on the dopamine system and reward system. So certainly there are risks of abuse and addiction with long-term use. Impaired driving, so that goes back again to that cognitive side effect of low reaction time or slow reaction time, impaired motor coordination. It's contraindicated in pregnancy and breastfeeding. So I would even extend that to contraindicated to patients that are trying to conceive. So even preconception, we know that cannabis can affect ovulation, and also from the male perspective, affect sperm motility and sperm health. So really important counseling fact when you're speaking to speaking to anyone in the childbearing age that is trying to get pregnant, that this is certainly not a safe option. And then obviously if the woman does get pregnant, it affects fetal development. And then furthermore, after birth, breastfeeding, we know that cannabis does get excreted in the breast milk. So that's all I'm going to say about cannabinoids, and there's lots of other, I know, e-learning and webinars that OPA has offered around cannabis. The other, agent that we don't want to forget about is topical therapies. Okay, so these are, therapies that are most effective for patients that have more localized pain. So certainly they have large areas of pain, let's say low back pain. These areas might not be the most effective because you would have to apply lots of it. But if you have more localized joint pain, these are things that could complement some of agents. So Capsaicin Cream, we know is derived from the chili pepper, and it's available on market at different types of concentrations noted here. The way it works is it depletes substance P from the unmyelinated C fibers, and it initially leads to this, what we call thermal hyperalgesia. So they have a burning pain, and then over time it becomes hyperalgesia, or hypoalgesia. So the pain subsides. So it's needed to be applied 3 to 5 times to that affected area for about 6 to 8 weeks before we actually see optimal pain relief. So this can be an agent that is effective for some, but a lot of people find it really hard to tolerate that initial thermal hyperalgesia, and it's not the most convenient because they do have to apply it many times to really get that full therapeutic effect. Other agents that I've seen in practice are compounded topical agents, and they come in a variety of different ingredients. I've just listed probably the most common ones I see. I've seen sometimes amitriptyline added in. So obviously you would have to have a compounding pharmacy of sorts to have these ingredients to be put into these creams to help with some neuropathic pain symptoms. And then lastly, there's lidocaine, so 5% gel, cream, or ointment, or the 2.5% patch. And again, lidocaine works essentially in the sodium channel blocker to minimize the perpetuation of that pain signal towards the central nervous system. The other topical agent I didn't put here, which we discussed earlier, is the Nsaids, right? So we talked about Voltaren already.
Okay, and lastly, this slide talks about some combo therapy, and I think we all do this. We all see this in practice, that I think the take-home message in a lot. So that's all I'm going to say about cannabis. Okay, and lastly, this slide talks about some combo therapy, and I think we all do this. We all see this in practice, that I think the take-home message in a lot of these older studies is that the use of combination therapy is more effective than single agent, and the thought is that combining different ways that these medications can target the pain pathway is better than just using one medication. And sometimes we can also get by using lower doses of each of these agents if we combine them, because there might be some synergistic effects. But again, the evidence looking at which specific combination is still quite low, but overall we use that very commonly in practice to combine different agents. Okay, so the last part of this talk, we're going to really focus on non-pharmacological management. And I think when we think about non-pharmacological, it doesn't mean it's non-medication and it's going to be less important. I think it's really coming to the forefront to being one of the top-line therapies that we really And much of our program at the clinic I work at the Toronto Academic Pain Medicine Institute here at Women's College in Toronto, our programs, our self-management program is really anchored on these non-pharmacological modalities because we really think and strongly believe they have good efficacy and safety for the patients. So physiotherapy is an anchor or a first-line therapy for all our patients. The physiotherapists focus on a biopsychosocial approach, so recognizing the biology of the pain and the body and where the pain is, the psychological interplay on pain, as well as the social aspects of the patient. And I would say that the biopsychosocial approach is a common thread throughout all the different modalities. The focus on physiotherapy, my understanding, is a graded exposure to movement. So the physiotherapists spend a lot of time addressing some maladaptive beliefs of movement and pain. So oftentimes patients may say, if I move a certain way or I exercise, I'm going to have more pain. Therefore, that means I'm causing more damage to my tissue. So they help to unravel some of these maladaptive beliefs that, in fact, movement, appropriate movement, is actually healthy. Help to decrease the fear of movement. So again, there's a lot of evidence showing post-analgesic effect, post-movement and exercise, to help the patient understand how to breathe. You think that is a very intuitive thing, but when we are in a pain flare, oftentimes we have very shallow breathing, right? So we're not breathing properly to help with a lot of the oxygenation of our muscles. So by proper breathing, we decrease that sympathetic upregulation and the stress hormone and cortisol production. Goal setting to improve movement and function, strengthening, conditioning, and flexibility, to name a few. The other big P, I guess, in non-pharms is the psychological modalities. And I've broken down to the two main types, and there's many other ones, but this is probably the two main ones that we offer in most pain programs. The first one being cognitive behavioral therapy, so CBT program. And the focus of this is to develop strategies to modify unhelpful patterns in thinking, which would lead to unhelpful patterns of behaviors, right? And some of these unhelpful patterns can lead to worsening pain experience and mood. Some skills that the clinicians would help teach the patient is behavioral activation, learning about pacing, stress management, relaxation techniques, cognitive restructuring, so restructuring of those negative thought patterns, sleep hygiene, anger management, and assertiveness. Another big program that we also focus on is mindfulness-based stress reduction. And a quote here is, it's essentially paying attention on purpose to the present moment, non-judgmentally to the unfolding experience moment to moment. So it's really being present and accepting their pain experience at the point and not judging what is going on through skills of body scan, mindful movement and yoga, mindful eating. There's meditative practice integrated into this stress reduction program. I'm also going to include a link in the next page, which we'll talk about. So I just showed you a diagram of what the link looks like. This is a 4-minute breathing space designed for quick meditative practice, and it's actually created by a team member from the Chronic Pain Service of the Toronto Rehab and the Rumsey Center at UHN by a clinician by the name of Kara Kircher. So you can Google this link and share this with your patients, but I think it's an excellent resource to use for patients. And we do this in a lot of our self-management programs, and it's just 4 minutes of breathing exercise, and I think patients are quite surprised after doing this that they, their shoulders drop, they're not clenching their jaw, they're much more relaxed, and it just takes 4 minutes. And if we can integrate this practice throughout the day or throughout the times when they feel a pain flare, it can be, very effective as opposed to maybe grabbing another Percocet. Using this practice as a point of a part of the toolkit to manage pain is very powerful. Other modalities, not to forget, is heat and cold, massage, TENS machines, acupuncture, biofeedback, distractions. So that could be visual distraction like reading or watching TV, listening to music, talking to friends. Relaxation, guided imagery. Hypnosis is a newer one, an interesting one that know some of our clinics, I know at UHN in one of our programs at Toronto General, the Transitional Pain Service, the psychologist actually uses hypnosis as one of her treatment modalities for really severe pain. Tai Chi and meditative movement. What I am going to just comment about these modalities, though there's not a lot of strong, let's say, randomized controlled trials or meta-analyses on the efficacy of these modalities, generally these are relatively safe. So I say to patients, if they find benefit for this in terms of pain coping, continue. Some of it can be cost prohibitive, but it's something that to add in as part of their toolkit, then continue to do this. The next big thing to remember, so we talked about, actual treatment modalities, but the other thing I think patients tend not to be aware about is self-management education. And that really is a foundation for all our programs at TAPME, that pain education is the foundation of pain treatment. Until you understand why you have chronic pain and understand the biology, and understand why you have flares and why, your mood worsens your pain. Until you understand that, it's very hard to start towards a movement of managing, right? So once you can understand your pain and understand all the nuances, then you can start to work on dealing with how it impacts your life and how you manage. So a couple of take-home messages before I talk about resources is that it's very key. We talked a lot about pharmacologicals. That's because as pharmacists, that's our main bread and butter and our value add. But I think it's also important as pharmacists to understand the non-pharmacological points of pain management. We want to treat to increase function and quality of life and not elimination of pain. So really important to realign expectation with the patient that we're here to manage your pain, not to take away all your pain. Give enough medications for an appropriate duration, so an optimal trial is key. A lot of patients we see in clinic are started on, the starting doses, let's say, of amitriptyline for a week. Patient says no benefit, then they quit it, right? And we recognize that there's not a lot of medications we can use for pain, so we don't want to prematurely rule out anything before giving a good optimal trial. So that's a huge education piece, both for the patient as well as for the prescriber. Use around-the-clock dosing, because we're in a chronic setting, so we want to be proactive as opposed to reactive. A combination of drugs for a multimodal approach, and then be mindful of combining multiple CNS depressant medications. The next few slides we're going to end off is different pain resources you can share with your patients. Oftentimes pain clinics are full, or there's really, really long wait list, or there's issues of cost to see a physiotherapist or see a psychologist. So these are really good resources you can share with your patients for them to explore at home as they wait or as they find other ways to engage in other active treatment. So Internet CBT, the Wilderman Medical Clinic, has an excellent program. It's consisting of 8 modules online CBT and mindfulness. It's for individuals with chronic pain with symptoms of anxiety and depression, and the website is provided for you there to explore. Another patient resource that's important to highlight for your patients is online chronic disease self-management programs. So through the Ministry of Health and Long-Term Care, they have funded these programs using the Stanford model of disease management. These programs are free. They can log on at their convenience 2 to 3 times a week for 2 hours per week. The workshop is led by trained facilitators. Groups of about 25 individuals participate. It's confidential, anonymous, and they talk about topics that are key to the management of chronic pain or any chronic condition. So really, really important core fundamental topics. So the website, I really encourage you to pass on to patients. The phone number is there to find out more about these programs when the next cycle is coming. So for patients to start managing. Couple more self-management programs. So these ones I believe are live programs. Another patient resource that's important to highlight for your patients is online chronic disease self-management programs. So through the Ministry of Health and Long-Term Care, they have funded these programs using the Stanford model of disease management. These programs are free. They can log on at their convenience 2 to 3 times a week for 2 hours per week. The workshop is led by trained facilitators, groups of about 25 individuals participating. Couple more self-management programs. So these ones I believe are live programs. So these again are free, evidence-based, peer-led, 6-week cycle. So providing education and skills for patients living with chronic conditions, pain being one of them. They're broken by the LINs. So I've listed there different locations. So the Toronto Central LIN, Markham, Toronto East, Mississauga, Central West, different links and phone numbers for your patients to find out more about these programs closer to their home. Okay, and then a couple more resources here for you, so websites of interest. So if there's programs that patients maybe aren't interested in, but they just want to read more about chronic pain, the Arthritis Society has a... Okay, so I'm going to end, of course, to pull a little plug for my clinic that I work at. So the Toronto Academic Pain Medicine Institute, the hub of chronic pain care in the GTA. Our website is there for you, and we have launched our website with lots of links to the previous resources I've mentioned, as well as lots of information. We're launching a lot of our self-management programs online because we do have patients coming to us from Kitchener or from Peterborough that can't come to our programs in Toronto. So we're actually pushing a lot of our programming online, and it's very interactive. It's a beautiful website. Our online referral form is also there for patients, not for patients, for prescribers and primary care providers. So if your patient is struggling with managing chronic pain and is looking for a chronic pain program, please direct them to our website, and their prescriber can work with them to fill out that referral. So how TAPME works is that it is a hub and spoke model. TAPME is the hub. It's based at a women's college, and the hub serves several purposes. We have clinicians there provide self-management programs and consultation. So I am part of the hub. So I work at women's providing pharmacist consultation to primary care providers that refer into TAPME, looking for medication recommendations, optimization recommendations, as well as a big part is on opioid rotation and tapering. So I get referrals from the community as well as from specialists, and then I would see the patient one-on-one and provide that in-depth consult to the doctor. And then also at TAPME, we are a triage referral. So essentially it's a one-stop shop. So anytime a primary care provider sends a referral to TAPME, comes to Women's College, we have a triage and referral team made up of nurses and occupational therapists, and they will look at the case and send it off to the most appropriate program. And you can see there's 5 programs that we're linked to, what we call our spokes. So the Center for Addiction, so we're not linked to the whole hospital, but we're linked to the chronic pain program. So the Center for Addiction and Mental Health has a program that is focused on chronic pain, opioid or substance misuse, as well as mental health. Sinai Health Systems, the WASR, is a medical managed program. So currently their doors are closed because of very long wait times. So they're working through their backlog, but traditionally they have been managing patients with those different types of pain conditions. St. Michael's Hospital, their focus is interventional pain as well as neurostimulation program. Women's College ourselves, we also have an interventional pain program and our hub. And then UHN is a massive program. They have interventional pain services, transitional pain services. So that's for the perioperative patients, so pre and post-op patients that struggle with chronic pain. And as well as Toronto Rehab, they have a comprehensive pain service there. So that's why we are considered the hub of chronic pain service in Toronto.
couple more things I want to highlight around the TAPMI program is our model of care. So you can see in this schematic that when patients are admitted into TAPMI, we try to have touch points with them throughout that journey of care. So right from the beginning, the primary care community or the primary care doctor, we have developed online education and tools to support primary care as it relates to chronic pain management. We have really simplified a referral form for our docs. So the referral form is, I believe, 3 to 4 pages available online on our website, as well as there's opportunity for e-consultation with some of our pain specialists. There's programming around ECHO, which I've discussed earlier, which is our kind of our online mentorship program with pain specialists out of TRI or the Toronto Rehab. And then we have our mobile clinic, which is a newer program or newer service delivery that we offer to primary care providers that have very challenging patients, and whereby there's no programs within the TAPMI program that patients can benefit from. So it would be myself and a pain physician would actually go out mobilely to the family doctor to work in a shared care model with their patient for one-time consults to provide some of that pain management strategy and support. Then you have central triage and intake. So we're trying to develop, standardized care plans and care pathways for common pain conditions once they enter TAPMI. So at least all the partners that we discussed earlier are practicing in a standardized manner and evidence-based manner with regards to different pain conditions. The foundational pain services. So this is the area where I work as a pharmacist. So I support what we call the hub services. So TAPMI is based out of Women's College Hospital in Toronto, and this is where we have a mix of healthcare professional support as well as treatment or pain self-management programming. Some hub services you can see listed here is pain education class. So this is a one-time 3-hour education class for all patients admitted to TAPMI to provide them that good foundation around how we approach pain management. I offer a cannabis class monthly to patients that are interested to learn about cannabis and pain. And then we have a slew of other self-management courses that I've listed here. So our acceptance and commitment therapy, MBSR, which is mindfulness-based stress reduction. So that's what we call our psychosocial programming. We have a Pain U program, which is Pain University. So that's a 9-week pain self-management program. We have PT, OT, myself, and a social worker. So really interdisciplinary support within the hub to equip patients with skills before they move on to the other specialty clinics, which is listed in the green there. So again, just reiterates our partners that I've discussed before and kind of some of the services they provide. And then finally, after they finish our hub services, seeing the specialty clinics, then they're discharged from TAPMI. So again, we're trying to really build up our online resources and education tools for GPs and patients after they leave our program, should they need further support. So they can come back to the website and continue that management of chronic pain. And there's also some talk of booster sessions where patients may come back, maybe in